Again, thank you very much, Martina. So next on our agenda, oh wow, that's really loud. We have is a topic that holds both importance and relevance for anyone involved in healthcare, especially those in patient care roles. So we are honoured to welcome Clare, a clinical nurse specialist from Colchester Hospital. In her presentation titled A Day in the Life of a Clinical Nurse Specialist, Clare will provide us with an in-depth look into the multifaceted role of a specialist nurse. Clare's insights will not only help us understand the vital role that nursing specialists play in patient care, but will also give us a glimpse into the depth of compassion, skill and knowledge required to be in such a role. So please join me in giving Clare a warm welcome.
A bit about me. I am a clinical nurse specialist and I work in oncology, looking after skin and renal oncology patients, as well as being the surveillance service in our local hospital for ocular melanoma. I have two cheeky chaps at home who it's quite nice to get a full night's sleep away from last night. And I've been working in oncology since I qualified. So I've been a nurse for 14 years, 12 of those years within ENT and head and neck cancers. And then after having my second son, I decided to work a bit closer to home. And that's when I entered the world of melanoma, renal cancers, and ocular melanoma. And it's been a learning journey that I've very much enjoyed. And as Jo said earlier about feeling like her job for Ocumel is easy, I also feel like my job as a specialist nurse is easy, because as long as I'm able to give somebody a benefit within my role, then I've done my job well. So I've got a quick question for you all as patients and relatives. How many of you have specialist nurses that are oncology based rather than just at Moorfields? A few. Not enough, I think is the answer. So my role as a specialist nurse, and this isn't an exclusive list, this is what I could really think of when I was writing this, and there will be more, but it's quite extensive of what a specialist nurse can offer you that is oncology based, or any specialist nurse really. But my role as a surveillance nurse for ocular melanoma is to be there for you, to be a first point of contact into the hospital, so you don't have to go around the houses trying to get through to somebody. I'm accessible, responsive. I help navigate the pathway, navigate you through treatments. I'm there after the appointment with the doctors to help support you and your relatives. I can explain treatments and weigh up options, because treatment isn't always right for everybody. People sometimes don't want to go through anymore when they've already been through a lot previously. I'm there to help. I was talking with the lady next to me, and sorry, I've forgotten your name already, about the cost of cancer, and actually, travelling to London and other centres, it comes with a financial burden. So I can talk to patients about grants that are largely supported by Macmillan for travel costs and other things that people are entitled to, because Macmillan is a great wealth of information. I help to arrange prescriptions. GPs in the UK, renownedly, are not very easy to access. If I say to a patient, if you go to a GP to get this, they always sigh down the phone. But I can send an email, and the GP will act on that email, and that is taking the pressure off of the patient. And that's the other side of my role, is to support you, but to take the pressure off. How can I help make your life easier? Next slide, please. This is just some patient feedback from an ocular melanoma patient. She's quite young. She works full-time. She's got 2 children too. And she says that you're there beyond the doctor. The doctor is there to tell you the words that you don't want to hear, but the nurse is there to answer the questions that you might not want to ask a consultant, because some patients still feel like there's inappropriate questions to ask a doctor, but are more relaxed with a nurse. We're here to encourage questions and encourage challenging. What does this mean for me, rather than just being told what to do? And we're there after the appointment to help pick up the pieces. Next slide, please. So has anybody here had a holistic needs assessment completed? So Macmillan, this is a busy slide. Yeah? Oh, that's good. Yeah, that is. So Macmillan introduced holistic needs assessments for clinical nurse specialists and their teams to perform, and its sole purpose is to encourage conversation. So realise that you're not there alone. There's nothing that we can't talk about, and if we can't help with something, we'll find somebody who can. So in my patient leaflet, after I've had my first contact, I will send this out and encourage patients to ring me if there's things on there that they want to talk about. But we also do this quite informally as a specialist nurse. So every time I ring a patient up, there's certain things that I will ask every single patient. How are you? Are you working? Are you struggling? How is your family? And it's to try and open dialogue. And then if you've helped one person, they might tell the next person that you can have this, that, your nurses can talk to you about this. So once we've done a holistic needs assessment, we'll explore how best for you as an individual can we help. Is it that I contact your GP? Do you have a good relationship with your GP so you can contact them? So we develop a care plan that gives me as a specialist nurse, but yourselves as well as a patient, different things to take away and do, and then we'll come back together in a different consultation, usually over the telephone, to see how we've got on and what can we help with next. Next slide, please. So the biggest part of my job is emotional and psychological support for patients and relatives. And I think hearing Dimmy's presentation made me realise how important my conversations with the relatives are. Because as a patient, you are the person going through this. And you are the person receiving the treatment and having the side effects. But your loved ones are there to support you, but they also need support. And they need an open access to ask difficult questions, to seek support that they might not always want you to know about. So I do have a lot of conversations with relatives without the patients knowing. I have a lot of relatives, one in particular, email me and go, oh, so-and-so's struggling at the moment, please, can you call her? And then I'll ring the patient, and she's like, you always ring at the right moment. But that's because her loved one knows her. He knows her the best, and he knows when she needs help. But she isn't the type of person to actively seek that help. So it just works. We get additional training in psychological support and communication skills. At Colchester, we're very lucky. We've got 2 Macmillan counsellors dedicated on site that we can refer into. We also have a young adults therapist who is dedicated to patients below 40. We have our hospice that we can refer to as well that has their own psychological support, and obviously Ocular's own therapists. At Colchester as well, and most hospitals do have this now, is a cancer wellbeing centre. And having these difficult consultations with doctors, it's not easy to walk out of that clinic appointment. You don't want to go and face the real world. Sometimes you just need a quiet space to just take 5 minutes before you take that car journey home or you get on a bus with other people. And the cancer wellbeing centres are there to provide a non-medical ear, a cup of tea, just a calm, quiet space for you to sit before you then move on to travel home. But they also provide holistic therapies. They've got massages, gong baths, life beyond cancer, workshops, support groups. They're a real wealth of information. So palliative support is, again, a very large part of my role. A lot of my patients, among all 3 topics that I cover, are in the palliative sector. Now, palliative doesn't just mean that you're dying. You can be diagnosed with something that we know we can't cure, but you're going to receive treatments. And some patients struggle quite a lot with that term. But I've been told I'm palliative, but you're still going to treat me. And there is discussion among us, are we going to change the language that we use to make it less scary and more understanding what kind of pathway patients are really under. But I'm there to give psychological support, discuss quality versus quantity of life, have these awkward conversations and open these conversations, because some of these treatments are really harsh and patients don't always want the treatment but don't feel that they can necessarily have that conversation with their loved one either. So I can help to support that process And then in clinic with the consultant, I can be there to navigate an appointment to let the patient have their voice. Because patients typically are guided by a doctor, but sometimes it's difficult as a patient to say, I don't want this treatment, because you feel like you should. So as a specialist nurse, I'll have multiple conversations with patients and then bring that back to clinic so that we can make the right choice for that individual patient. So a patient will ring me up who's not on treatment and said, oh, I've got this new pain. I'm trained to clinically assess a patient, navigate their symptoms, see what do I really think it is, but who's going to be best appropriate to manage that? Is it time that they're referred to the hospice for symptom management, or can I support this patient a bit longer with the GP and email the GP and get prescriptions, or can the patient come and collect a prescription from the hospital, or do they need a prescription at all? There are alternative therapies and non-medical treatments available for everybody, but it's about accessing the right person who's got the knowledge. And soon that will improve because I'll be able to prescribe, hopefully if I pass the course next week. Inpatient visits. Coming into hospital is something that nobody wants to do. And one of the patients who does link in with Ocular, she tested positive with COVID at the same time as she had liver toxicity to immunotherapy. She wasn't allowed relatives, but I was allowed to go and see her. So it felt cruel that she wasn't allowed her loved ones there, but I could go whenever I wanted. And her comments were, you're the regular face, the familiar face. I look forward to your visits, because the nurses are busy on the ward, they flit in and out. But as a specialist nurse, I have that time, and I have that ability to come and see you, spend half an hour. Like, it doesn't matter, that is my job. I will expedite treatments, escalate things, chase people, say to the bed managers, this patient just needs this scan and then they can go home. When they hear that, that's music to their ears. But you have to have the right person to speak to the right person to get things done. And I can liaise with relatives who may be at work, or the patient doesn't know how to quite communicate a new diagnosis or a new result to their relatives, and I can be there to support those conversations. Nurse-led clinics. All of our ocular patients at Colchester, under surveillance and non-active treatment, fall under a nurse-led clinic. There hasn't been a patient yet who doesn't like that service. We ring people after an ultrasound within 2 to 3 weeks of the ultrasound, because we know we get the reports back really, really quickly. We do have a backlog locally with other imaging results, but we're working on improving that. But you build that relationship and you build a rapport with these patients. You know what they're going through and can help them at different periods. And there's some feedback at the end that kind of reflects this. With increasing treatments for, sadly, not ocular melanoma, but other cancers, increasing patient numbers, the nurse-led clinics are definitely going to be advancing in healthcare. So as a clinical nurse specialist, I need to be easy to contact. You don't want a clinical nurse specialist that you wait 3 days for a reply or you don't get a reply. So we have 3 communication methods: text, email, and phone. I encourage patients to text me in the middle of the night, not because I'm going to answer, but because the phone will be off and I'll pick it up in the morning, but they might have forgotten that question in the morning, or they might be too busy to then remember to send that question. So same with emails. You can email me when it's best for you, and I'll email you as soon as I can back. There should be more specialist nurses out there to support patients like yourselves with ocular melanoma. And I think I didn't realise how little specialist nurses there are supporting patients like yourselves until today. And I'll work with Ocular to try and increase that, and I'll link in with Adam Brooks to try and improve our links as well. Local support groups, we don't have an ocular melanoma support group locally, but it's something that I'm definitely willing to work on. And there are definitely key patients that I think would very much benefit and maybe even be an ambassador. So patient feedback, this is quite long. But this lets me know that I'm doing my job right. And this is what drives me to continue. Thank you.